Welcome to Nursing World's NCLEX Contents Review class. Today we'll be looking at some therapeutic procedures you need to know, like CVP, chest physiotherapy, chest tubes, ear procedures, ENEMAS, eye procedures, nasogastric tubes, oxygen therapy, suctioning, surgical drains, tracheostomy, and urinary catheters. As usual, we're going to start with a quiz and we'll use our decision tree to solve it. So a client has a CVP monitor in place, which will be included in the nursing care for this client. A, notify the physician of readings less than 3 cm or more than 8 cm of water. B, use the clean technique to change the dressings at the insertion site. C, elevate the head of the bed to 90 degrees to obtain CVP readings. And D, the 0 mark on the manometer should align with the client's right clavicle for the readings. Let's use our decision tree. We start with step 1 and then we'll move to step 5. So let's evaluate option A. The normal reading for central venous pressure is between 3 and 8 cm of water. So the doctor should be notified of any abnormal reading. Okay, so that is a good answer choice. We'll have to hold on to that. How about B? Well, you look at when we talked about our decision tree and how you could use them, we said you should always note out for keywords. So you can see clean technique, that already tells us that option is incorrect. C is also incorrect because of the 90-degree angle. With CVP, we know the angle should be, the patient should be supine and the angle should be up to 45 degrees. Okay, so how about D? D is also wrong. The 0 on the manometer should align at the phlebostatic axis, the fourth intercostal space, mid-axillary line, instead of the right clavicle. So D is also wrong. So our correct answer option is option A. Okay, let's do another quiz to get us in the mood. The nurse is observing a graduate nurse as she assesses the CVP. Which observation would indicate that the graduate nurse needs further teaching? Okay, so we're going to use our decision tree again. We'll start with step 1 and move to step 5. So let's evaluate. A, the graduate places the client in a supine position to read the manometer. B, the graduate turns the stopcock to the off position from the IV fluid to the client. C, the graduate instructs the client to perform the Valsalva maneuver during the CVP reading. And D, the graduate notes the level at the top of the meniscus. Well, I won't like to waste so much time breaking down the decision tree, but we know that answer C is our correct answer option. The client should not be instructed to do the Valsalva maneuver during the CVP readings. If the nurse tells the client to perform the Valsalva maneuver, then that nurse needs further teaching. So answer A, B, and D are all incorrect because they actually indicate that the nurse understands the correct way to check the CVP. So there's also another quiz again. Okay, let's run through that also. A client with burns is admitted and fluid resuscitation has begun. CVP readings are ordered every 4 hours, okay? So using our decision tree, we're looking at our keywords every 4 hours. The CVP reading is 14 cm of water. Which evaluation by the nurse is most accurate? So what does that tell you using your decision tree? Most accurate. Okay, so we start with step 1 and move to step 5 again. And we know that answer A, the client has received enough fluid. B, the client's fluid status is unaltered. C, the client has inadequate fluids. And D, the client has a volume fluid excess. Okay, if you use our evaluation, we know that answer D is the correct answer choice. The normal CVP is 3 to 8 cm of water. So an elevation in CVP actually indicates a fluid volume excess. So answers A, B, and C indicate that the reading is normal or low. So they're actually incorrect. Now let's look at central venous pressure. The purpose of CVP is for measurement of effective blood volume and the efficiency of cardiac pumping. It also indicates ability of the right side of the heart to manage a fluid load. CVP also helps as a guide to fluid replacement. So what equipment you need if you want to set up your CVP? You need a central line that would be threaded into the right atrium. You also need a water manometer with a 3-way stopcock. And again, you need your IV fluids. So let's look at the procedure for setting up our CVP. So you're going to have the client, or you have the catheter in the client's jugular or the subclavian or the antecubital vein. You want to attach the manometer to a 3-way stopcock that also connects IV to a central line. So here's our manometer. So this is our manometer, and this is our IV line, and this is the line coming from the patient, the catheter from the patient. So this is your 3-way stopcock. So it's 3-way because it connects to the manometer, it connects to the patient, and it also connects to your IV fluid. Okay. Again, you want to set the 0 point, which is this, the 0 level on the manometer. It should be placed at the phlebostatic axis. So these are keywords. Like we said, our NCLEX review course doesn't take you through the whole stuff. We give you the details, the content you need to know. Okay, so there's another important point. Your 0 point on the manometer must be placed at the phlebostatic axis, which is a line from the 4th intercostal space at point where it joins the sternum, and a line midway between the anterior and posterior surface of the chest at the outermost portion of the sternum. So midway from the 4th intercostal space. So if we count, somewhere around here should be our 4th intercostal space where it joins the sternum, okay? And a line midway between the anterior and posterior surface of the chest at the outermost part of the sternum. So that is where your 0 point, you want your 0 point to be at the phlebostatic axis. Okay, so usually CVP is measured with the client flat in bed or elevated up to 45 degrees. Remember, we saw that in our quiz. And first of all, the stopcock is opened to the manometer. So this is your manometer. So you open the stopcock, so you sort of close out the fluid from going this way and open the stopcock to the manometer. So it will allow fluids from the IV to fill up the manometer. And you want to fill it up to a level of 18 to 20 centimeters of mercury. So you want to fill it to 18 to 20 centimeters of mercury. That's where your level should be on the manometer. And after that, the stopcock again is turned to allow for fluid in manometer to flow to the patient. So this time around, you're closing up this area, and then you're opening up this area to allow the fluid flow to the patient. Okay, so you're closing up this area to allow the fluid flow to the patient. Okay, and the level of fluid will fluctuate with respirations. You'll see the level of fluid in the manometer fluctuating with respiration. When the level stabilizes, the reading is taken at the highest level of fluctuation on the manometer. Okay, so that's where you take your reading from, when the fluctuations have stabilized. Okay, and then after that, once you've taken your readings, you can then return the stopcock to proper position and adjust IV flow rate. So then you can open up the line, can close up the manometer and allow the IV fluid continue. So like we said, you'll get different ranges actually from different textbooks and all, but as a guide, the normal reading should be between 4 and 12 millimeters of mercury. But you can also have some, so if it's elevated actually, if it's greater than 12, then we know the patient is what, hypervolemic or has some poor cardiac contractility if the levels are greater than 12. But if it's less than 4 millimeters, we know the patient has very low fluid or circulatory volume or is hypervolemic. So that gives you a guide. So we said the possible complications could include, while we're inserting the needle or the catheter, there could be a pneumothorax, there could also be embolism, there could also be infection at the insertion site. And what's your nursing care for this patient? You want to keep a dry, sterile dressing over the insertion site. And again, you want to change the dressing, the IV fluid bag, the manometer, and the tubing every 24 hours. You want to instruct the client to hold his breath, which is a Valsalva maneuver, when inserted and or when the catheter is withdrawn, or when the tube is changed. Why are you doing this? Because you want to prevent embolism. So instruct the client to hold the breath. Remember, like we saw in the last quiz, you don't ask him to do this when you're taking the reading. You only do this when the line is inserted or is being withdrawn, or when tubing is changed. And again, you want to check and secure all connections on your patients. Okay, so let's look at this quiz again and use our decision formula. The client has surgery for removal of a prolactinoma. What's a prolactinoma? We know a prolactinoma is a type of pituitary tumor, or the pituitary gland is a non-cancerous tumor. Okay, so which of the following interventions would be appropriate for this client? Place intradental position for postural drainage, encourage coughing and deep breathing every 2 hours, elevate the head of the bed 30 degrees, encourage the Valsalva maneuver for bowel movements. Okay, elevate the head of the bed. Remember, you're looking at your outcomes when you use this decision tree. What's the outcome for each option? So I'm just going to go straight to the answers. We know that elevating the head of the bed 30 degrees would avoid pressure on the sella turcica, and it will help to prevent headaches. So that is a good outcome. That is what I want when I want to elevate. That's the outcome I want when I elevate the head of this bed. So options A, B, and D are incorrect because all of these would increase intracranial pressure. Remember, this patient just had a surgery or a surgical procedure to remove that tumor. So we don't want to increase intracranial pressure. Okay, the physician has ordered aerosol treatments, chest percussion, postural drainage for a client with cystic fibrosis. The nurse recognizes that the combination of these therapies is to, again, you want to use your decision tree. Okay. So what's cystic fibrosis again? Because you need to know what your topic is if you're using the decision tree. Remember, that's the first step. Okay, we know cystic fibrosis is an inherited life-threatening disorder that damages the lungs and the digestive system. It affects mostly the cells that produce mucus, that produce sweat, that produce digestive juices. So it causes these fluids to become thick and sticky. And when they are thick and sticky, what happens? They begin to plug up the tubes, plug up the ducts, plug up the passageways. So obviously, answer C is our correct answer option, because the objective of this therapy using aerosol treatment and chest percussion and postural drainage is to dilate the bronchioles and help to loosen these secretions. So A, B, and D are incorrect. So let's look at some chest physiotherapy. One of them would be, we'll need to consider breathing exercises. It could be diaphragmatic or abdominal breathing, or it could be pursed lip breathing. In diaphragmatic breathing, the client is positioned on the back with his knees bent, and then he places his hands on his abdomen and he does the breathing exercise. In pursed lip breathing, which would be this, in pursed lip breathing, the client is instructed to breathe in through the nose and then purse his lip, like tighten his lip, purse his lip, and then breathe out through the mouth. And again, you want to instruct the client that exhalation should be twice as long as inspiration. Please take that down. Exhalation should be twice as long as inspiration. That's when you can say, yes, this client is carrying out post-sleep breathing. Okay, another chest physiotherapy would be coughing techniques. Here, you want to instruct the client to lean slightly forward and take 3 slow, deep breaths through the nose, exhaling slowly through slightly parted or pursed lips. And then after, the client should then take another deep breath and cough several times during expiration. You know, like, you want to encourage the client to cough from deep within the chest and avoid non-productive coughing that wastes energy. Okay, so have him take 3 slow, deep breaths through the nose, exhaling slightly through pursed lips, and then take a very good deep breath and cough several times during expiration. So that's your coughing technique. Okay, you could also use postural drainage, and this uses gravity to facilitate removal of bronchial secretions. Okay, so here the client is placed in a variety of positions to facilitate drainage into larger airways. Some common positions used are the head down position, the prone, the right and left lateral, the upright. Again, you want the client to stay in each position for between 10 to 15 minutes. And he should breathe in slowly through the nose, breathe out through pursed lips. And this should be performed 2 to 4 times daily before meals and at bedtime. Secretions may also be removed by coughing or suctioning. In percussion and vibration, this is usually performed during postural drainage to augment the effect of gravity drainage. Okay, so in percussion, when this is a rhythmic striking of the chest wall with cupped hands. So you can see the position of the hands. The hands has to be cupped. So you're using cupped hands, striking the chest rhythmically over areas where secretions are retained. But in vibration, the hand and the arm of the person, the arm and hand muscles of the person doing vibration, they are tensed, and a vibrating pressure is applied to the chest as the client exhales. Okay, one of your nursing considerations there is you want to put a towel over the area, and you can alternate the percussion with vibration, 5 minutes in each position. Another chest physiotherapy will be the use of incentive spirometer or spirometry. This is used to maximize respiration and also mobilize secretions. Okay, you want the patient sitting in semi-Fowler's position, and then you guide him, put the mouthpiece in your mouth and close your lips tightly around it to form a seal. So you can see the equipment of the mouthpiece. You should put the mouthpiece and form a seal around it, okay? Do not block the mouthpiece with your tongue. And then inhale slowly and deeply through the mouthpiece to raise the indicator. Before now, you'd have set a goal, but this is where we want the patient to raise the goal line to, okay? So inhale slowly and deeply through the mouthpiece to raise the indicator. Try to make the indicator rise up to the level of the goal marker. When you cannot inhale any longer, remove the mouthpiece and hold your breath for at least 3 to 5 seconds to achieve effective lung expansion. Then you can exhale normally. And he needs to repeat these steps 10 to 12 times every hour when he's awake. Okay, a client has a chest tube inserted following a left lower lobectomy required by a stab wound to the chest. While repositioning the client, the nurse notices 200 cc's of dark red fluid flow into the collection chamber of the chest tray. What is the most appropriate nursing action? Okay, so we're going to use our decision tree again. We know our topic. We know these are all implementations. Looking at them, we know they're all physical. We can eliminate B in step 4, and then let's evaluate our remaining answer options. Okay, so we know the correct answer is D, because we need to continue to monitor the rate of drainage. Remember, the question says, the stem of the question says the client was repositioned. So we should continue to monitor, because it's not unusual for blood to collect in the chest and be released into the chest drain when the client changes position. So the dark color of the blood indicates it is not fresh bleeding inside the chest, okay? So you can see from the stem of the questions, we already have so much information that guides us to this. Okay, another quiz. The nurse is giving an end of shift report when a client with a chest tube is noted in the hallway with the tube disconnected. So look at the stem of the questions. What's our topic? Now, what is the most appropriate actions? Okay, so we can use all 5 steps of the decision tree. Okay, we know these are all implementation options. Clamp the chest tube immediately. Put the end of the chest tube into a cup of sterile normal saline. Assist the client back to the room and place him on his left side. Reconnect the chest tube to the chest tube system. Okay, we know these are all implementations. They are all physical. We can't eliminate in step 4. We evaluate our answer option choices. Okay, so answer A, clamp the chest tube. You don't want to do this. This could cause a tension pneumothorax if the client has no escape for the air. So you don't want to do that. B is our correct answer option. The nurse must provide a water seal immediately. Answer C serves no purpose. And D would not allow maintenance of a sterile system. Another quiz, the chest tube drainage system has continuous bubbling in the water seal chamber. When the nurse clamps different areas of the tube to find out where the bubbling stops, he is checking for an air leak, the suction being too high, the suction being too low, tension pneumothorax. Okay, we'll also see this when we talk about chest tubes. The only times you're allowed to clamp the chest tube. Okay, so if we use our decision tree, we know these are all implementations and they are all physical. And we know that answer A is the correct answer option. You know, clamping various areas of the tube allows the nurse to assess for a leak in the tubings. When the bubbling stops, then the leak has been located. Answer B and C are assessed by reading the suction gauge, if you want to know if it's too high or if it's too low, and observing the bubbling in the suction control chambers. So it makes those wrongs. And answer D is a diagnosis confirmed by client symptoms and X-ray not related to the chest tube system. So let's look at chest tube, which is another therapeutic procedure. We know that it's an intrapleural drainage system with one or more chest catheters held in pleural space by suture to chest wall, which is then attached to a drainage system. So we can see our chest tube here in the pleural space. Sutures could be used to hold it in place, then it's attached to a drainage system down here. So what's our nursing care for patients with a chest tube? Remember, you want to fill the water seal chamber. You want to fill the water seal chamber. So this is our water seal chamber. So you want to fill the water seal chamber with sterile water to the level specified by the manufacturer. If suction is to be used, you want to fill the suction control chamber with sterile water to the 20 centimeter mark. Okay, if suction will be used, you want to fill the suction control chamber with sterile water to the 20 centimeter mark, or as ordered by the healthcare provider. Again, encourage the client to change position and cough and deep breathe frequently. The drainage system must be maintained below the level of insertion without kinks in tubings. Chest tubes are clamped only momentarily to check for air leaks. We saw that in our questions. And again, to change the drainage apparatus. So those are when you want to clamp your chest tubes, to check for air leaks and to change the drainage apparatus. Again, as a nurse, you want to observe for fluctuations of fluid in the water seal chambers. And usually the fluctuations would only stop when the lung has re-expanded. Fluctuations will stop if the tubing is obstructed. It could also stop if the loop hangs below the rest of the tubings. So those are times when the fluctuations might stop. your drainage system. So when we want to remove the chest tube, we need to instruct the client to do the Valsalva maneuver, like forcibly bearing down while holding your breath. The chest tube is then clamped and quickly removed by the healthcare provider. Okay, you can see it's clamped and quickly removed by who? The healthcare provider. And then an occlusive dressing is applied to the site. What are some complications? Okay, you want to observe for constant bubbling in the water-sealed chamber. Okay, you want to observe for constant bubbling because this indicates actually that there's an air leak in the drainage system. You need to report this to the healthcare provider immediately. So if you note, we're not talking of fluctuations here, we're talking of constant bubbling. It indicates an air leak in the drainage system. Report to the healthcare provider. Again, if the chest tube becomes dislodged, apply pressure over the insertion site with a dressing that is tented on one side to allow for the escape of air, and then immediately report to the healthcare provider. Okay. If the tube becomes disconnected from the drainage system, cut the contaminated tip of the tubing, insert a sterile connector, and reattach to the drainage system. If this is not possible, immerse the end of the chest tube. Immerse the end of the chest tube in 2 centimeters of sterile water until the complete system can be reestablished. And then you want to report to the healthcare provider. If you notice in some of these answers, the nurses should not just pass the buck. Remember, we talked about this in our video on the rules to the NCLEX. Don't pass the buck. You can actually do something before you report to the healthcare provider. So the physician has ordered corticosteroid eardrops for a 2-year-old. To administer the eardrop, the nurse should do what? Well, we're not going to spend so much time on this, but we know answer A is correct. When administering eardrops to a child under 3 years of age, the nurse should pull the ear down and back to straighten out the ear canal. So A is our right answer option. So still on therapeutic procedures, we're looking at ear procedures. There's 2 of them on the screen. We have ear irrigations and we have ear drops. So considering ear irrigations, if you want to irrigate the ear, you want to tilt the head toward the affected side or toward the side of the affected ear. And you want to gently direct stream of fluid against the sides of the canal. So you can see your fluid is directed on the sides of the canal, not directly on the eardrum. Okay, and after the procedure, you want to instruct the client to lie on the affected side. Why? Because you want to facilitate drainage of the stream of fluid we push into the ear. Again, this is contraindicated if there's evidence of swelling or tenderness in that ear. Okay, so let's look at ear drops. Okay, position the affected ear uppermost because that's where you want to put the ear drop. Pull outer ear upward and backwards for adults. So please note this difference. So this is for adults. You want to pull outer ear upwards and backwards. And then for a child, you want to pull outer ear downwards and backwards. So both of them, you're pulling backwards, but for the children, downwards, for adults, upwards. Okay, but you can see the steps. Ear upward first, and then backward for adult. Whereas for children, downwards, and then backwards. Okay, so place drops so that they run down the wall of the ear canal, and then have clients lie on unaffected ear to encourage absorption of the eardrops. Okay, let's look at the quiz again. The nurse is caring for a patient with suspected diverticulitis. The nurse will be most prudent in questioning which of the following diagnostic tests: ultrasound, barium enema, complete blood count, completed CT scan. Again, like we said in our decision tree, if you haven't taken that class, I would advise you do. If you have a brain question, you should also have a brain answer. If you have a respiratory question, you should have a respiratory answer. If you have a gastro question, you should have a gastro answer. Just barely looking at this, I can see my barium enema, which is a gastro question, right? And we also have barium enema, which is directly related to gastro. So I'm already tilting towards that answer. Well, we know that is correct because barium enema is contraindicated in the client with diverticulitis because it can cause bowel perforation. So answer A, C, and D are appropriate diagnostic studies for the client with suspected diverticulitis. So these are some of the ways the decision tree helps you to arrive at the right answer. So let's look at enemas, which are instillation of solutions into the rectum and sigmoid colon. It's also used to promote defecation by stimulating peristalsis. So we have the oil retention enemas. These ones actually help to soften the feces. We have soap suds. These ones irritate the colon, causing reflux evacuation. You could also use tap water, which also helps to soften feces, stimulating evacuations, and it's also a volume expander. So what's the procedure for enemas? Again, you want to explain the procedure to the client. Position the patient in Sims position with the right knee flexed. Okay, so he's in your Sims position with the right knee flexed. Use tepid solution. Again, you want to hold the irrigation set at 12 to 18 inches, especially if you are giving high enemas. It should be at this level between 12 and 18 inches. But for low enemas, we can go as low as 3 inches for low enemas. Again, you want to insert the tube no more than 3 to 4 inches for adults. So 3 to 4 inches for adults. For children, you could go between 2 and 3 inches. And for infants, you can go between 1 and 1.5 inches. You want to ask the client to retain the solution, hold it in for 5 to 10 minutes. Again, you don't want to administer enemas in the presence of your patient complaining of abdominal pain, nausea, vomiting, or if you're suspecting appendicitis, you don't want to use enema in these conditions. Okay, the nurse is discharging a client with a prescription of eye drops. Which observation by the nurse would indicate a need for further client teaching? Shaking of the suspension to mix the medications, administering a second eye drop medication immediately after the first one was instilled. So I don't like this, immediately. Washing the hands before and after the administration of the drops, which is a good one. Holding the lower lid down without pressing the eyeball to instill the drops, which is another good practice. So answer B is actually correct. The client should at least wait 5 minutes before instilling a second eye medication. A, C, and D are correct procedures for eye drop administration. So there's no need for further instruction with this observation. So B is our correct answer option. Like I said, I'm just rushing through, but normally if you use the decision tree on this, it makes it a whole lot easier. Okay, so let's look at eye procedures. We're looking at eye drop installation. Remember, your equipment must be sterile. You want to wash your hands before installation. Do not allow the dropper to touch the eye, okay? You don't want to have any contact between the dropper and the eye. Do not allow drops from one eye to flow across the nose into the opposite eye. Tilt the head back and ask the patient to look up, and then you want to peel the lid down, okay? And you want to place the drops into the center of the lower conjunctival sac. Instruct the client not to squeeze eyes, but he can blink between drops. And again, to prevent systemic absorption, you can press the inner canthus near the bridge of the nose for 1 to 2 minutes. But for eye irrigation, you want to have the patient tilt the head back and toward the side of the affected eyes. Allow irrigating fluid to flow from the inner canthus to the outer canthus, okay? Use a small bulb syringe or eyedropper to dispense the fluid. You don't want to use so much pressure. and place a small bin close to head to collect excess fluid and drainage. Okay, the provider's order reads, aspirate nasogastric tube feeding tube every 4 hours and check pH of aspirate. The pH of the aspirate the nurse has checked is 10. Which action should the nurse take? Hold the tube feeding and notify the provider. Okay, a pH of less than 4 indicates that the tube is appropriately placed in the stomach, which is a highly acidic environment. So if we get a pH higher than 4, which is alkaline pH, it actually indicates intestinal placement. So A would be our correct answer option. So let's talk about nasogastric tubes. There are different types. There's a Levin tube. This will be a Levin tube, which is a single lumen stomach tube used to remove stomach contents, or you can also use it to provide tube feeding. There's a Salem pump, which is a double lumen tube, stomach tube, most frequently used for decompression with suction. There's a Miller-Abbott, which is also a double lumen tube, but it has a mercury-filled balloon and a suction port. So this would be your mercury-filled balloon. Okay, and then there's the Cantor tube, which is a single lumen tube with mercury-filled balloon and also a suction port. There's also the Harris tube, which is also another single lumen tube with mercury-filled balloon and a suction port. So these are some of the nasogastric tubes. We also have the Sengstaken-Blakemore tube. This is a triple lumen, so this would be your Sengstaken-Blakemore tube, which is a triple lumen gastric tube with inflatable esophagus balloon. So this is your esophageal balloon. There's also a stomach balloon or your gastric balloon. And then it also has gastric suction lumen used for treatment of bleeding esophageal varices. So remember, this tube is usually used when you have esophageal varices. Okay, there's also the Q-feed or Dobhoff tube, which is a soft silicone rubber medium length tube used for long-term feedings. The placement of this tube can be verified by X-ray. It takes 24 hours to pass from the stomach into the intestines. So you want to lay the patient on the right side, ask him to lie on his right side to facilitate passage into the intestine. So let's look at insertion of the Levin or the Salem sump. So first of all, you want to take the right measurement. You want to measure the distance from the tip of the nose to earlobes. So from the tip of the nose to the earlobes. So you place the tube from here to this point. And then the distance from the earlobes again to the bottom of the Seifert process. Okay, and then you want to mark the distance on the tube with tape, not with a marker, with tape. And lubricate end of tube with water-soluble jelly. Insert the tube through the nose to the stomach. You can offer the patient sips of water while you advance the tube gently. Bend the head forward. This will help to close the epiglottis, closing of the trachea. Observe for respiratory distress, which will be an indication that the tube has been misplaced in the lungs. If incorrectly, please secure with hypoallergenic tape. Verify placement of tube initially and before administering feeding. And your X-ray is the only sure way to verify placement. Aspirate gastric contents. Observe color. Usually gastric aspirates is cloudy and green. It may also be off-white. It could be tan. It could be bloody or brown. Measure pH of your aspirate. Gastric pH, usually less than or equal to 4. Intestinal pH, usually greater than 4. Respiratory pH, usually greater than 5.5. Your nursing care for a client with a Levin or a silent pump, always check residuals before intermittent feeding, every 4 hours with continuous feeding, and hold the feeding if your residual is more than 100 mils. Okay, again, you also want to instill 15 to 30 ml saline or water according to your agency policy. And when do you instill this? Before and after each dose of medications and each tube feeding. You also want to instill 15 to 30 ml of saline or water after checking residuals and pH. You can also do this every 46 hours with continuous feeding. Again, you can also instill 15 to 30 ml of saline or water when feeding is discontinued. Again, you want to control the rate of feeding. Use an enteral pump or a count drops in gravity administration. That way you're able to control the rate of feeding. You also want to administer fluid at room temperature. Change the bag every 24 or 72 hours. Elevate head of bed 30 degrees while feeding is running, and for 30 minutes after feeding. 30 degrees while feeding, 30 minutes after feeding. Check patency every 4 hours. Document any drainage. Measure your intake and output. Offer good mouth care. You know the tube has gone through the nose, so you want to lubricate the tube around the nares with water-soluble jelly. Okay, hang the amount of fluid that will be infused in 4 hours, not more, not less, just the amount that will be infused in 4 hours. Let's look at irrigating your Levin or salon pump. Like we said, before you do this, you want to verify placement of the tube. Now you can insert 30 to 50 ml syringe filled with normal saline into the tube and inject slowly. If you feel any resistance, check to see if the tube is kinked and have the client change position. Pull back on plunger or bulb to withdraw solution. If irrigating solution is not removed, please record that as input and repeat if needed. When you want to remove your tube, first of all, you want to clamp the tube and remove the tape. And then you want to instruct the client to exhale. And then you remove the tube with smooth, continuous pull. That's how you remove your Levin and salon sump. If we're looking at insertion of intestinal tubes, like your Cantor tubes, the Miller-Abbott tubes, the Harris tubes, these are your intestinal tubes. It's actually, insertion is actually through mechanical passage into the stomach, same as your NG tube. The passage of this tube along the intestines is aided by gravity, is aided by the weight of the mercury that comes with the tube, and also by peristalsis. Okay, so after the tube is in the stomach, have the client lie on the right side, then on his back in Fowler's position, and then on his left. What are you trying to do? To use gravity to position the tube. The position again is ascertained by X-ray. Do not tape the tube to face, but just coil it loosely on the bed. The position of tube, an absence of telescoping of bowel from weight of tube is ascertained daily. How do you get that? By X-rays. What's your nursing care? You want to measure drainage every shift. You want to provide general client care, like with anybody who has an NG tube. You want to report signs of return of peristalsis, just like bowel sounds, bowel movement, or flatus. When we look at removal of intestinal tubes, please remember you want to clamp the tube. Again, you want to remove the tape. You want to deflate the balloon or aspirate contents of intestinal tube balloon. So that will help to deflate the balloon. Instruct the client again to exhale. And then you want to remove 6 inches every 10 minutes until the tip of the tube has reached the stomach. Then remove completely with a smooth, continuous pull. So remove 6 inches every 10 minutes until it reaches the stomach and then remove completely with smooth, continuous pull. A client has a history of COPD. As a nurse enters the client's room, his oxygen is running at 6 liters per minute. His collar is flushed and his respirations are 8 per minute. What should the nurse do first? I like all these questions that ask me, what do I do first? Because I know it's a priority question. I'm going to use my decision tree. But again, what's COPD? It's a group of lung diseases that block airflow and make it difficult to breathe. The most common conditions that make up COPD are like your emphysema, chronic bronchitis. Damage to the lungs from COPD cannot be reversed. And when if you see a patient with COPD, you will see symptoms such as shortness of breath, wheezing, or a chronic cough. Okay, so if we look at our answer option choices, obtain a 12 lead EKG, place the client in a high Fowler's position, lower the oxygen rate, take baseline vital signs. Like I said, if you have a respiratory question, you should have a respiratory answer, your decision tree. So if we use all 5 steps of the decision tree, we'll know that answer C is our answer option, lower the oxygen rate. We know that a low oxygen level acts as a stimulus for respiration. So if you have a high concentration of supplemental oxygen, this will remove the hypoxic drive to breathe, leading to increased hypoventilation. It also leads to respiratory decompensation and the development of or worsening of respiratory acidosis. Unless it's corrected, it can lead to the client's death. So answer C is our correct answer choice. Okay, so let's look at oxygen therapy as part of our therapeutic procedures. Oxygen could be delivered through your nasal prongs or nasal cannula, as you would like to call it, or your face masks. If we look at the nasal prongs, these are nasal prongs, we know that the oxygen delivered is at about 23 to 42% at a flow rate of 1 to 6 liters per minute. Again, as a nurse, you want to assess patency of the nostril. You want to apply water-soluble jelly every 3 to 4 hours and perform good mouth care for your patient. In terms of the face masks, we know that the oxygen delivered is between 40 to 60% at 6 to 8 liters per minute with an oxygen flow minimum of 5 liters. For your nursing considerations, please remove the masks every 1 to 2 hours. Wash, dry, and apply lotion to the skin. You also want to provide emotional support to decrease feelings of claustrophobia. If we look at the partial rebreather marks, so this will be our partial rebreather marks. The oxygen delivered is at about 50 to 75% at 8 to 11 liters per minute. As part of your considerations, you want to adjust oxygen flow to keep your reservoir bag 2/3 full during inspiration. It shouldn't go flat at any point, especially during inspiration. So it must be 2/3 full with oxygen. Okay, and then for your non-rebreather marks, which will be this, it can provide as high as 80 to 100% at 12 liters per minute. Again, adjust your oxygen flow to make sure this is 2/3 full, especially during inspiration. There's also the Venturi max. Okay, so this will be our Venturi max, which can deliver at about 24 to 40% at 4 to 8 liters per minute. Again, you want to keep tubing free of kinks, so that will be your major consideration. There's also tracheostomy collar. Okay, so this will be your collar, this will be your T-piece. It can deliver at about 30 to 100% at 8 to 10 liters per minute. Again, you want to assess for fine mist in the tubes. You want to empty condensation from the tubing at intervals. And again, you want to keep the water container full at all times. So that's your nursing consideration. Okay, this is your oxygen hood, which is used for infants and young children. It actually provides cooled, humid air. and can deliver at about 30 to 100% oxygen at 8 to 10 liters per minute. Your nursing consideration would include checking your O2 concentration with your O2 analyzer every 4 hours. Please, you need to do this. Refill humidity jar with sterile distilled water. Clean humidity jar daily. Cover client with light blanket and towel or cap for head. Change the bed linen frequently. And again, you want to monitor the client's temperature frequently. Okay, in terms of oxygen, we're looking at some of the complications or hazards of oxygen administration. There could be infection. What can you do to reverse that? Change the marks, change tubing, change mouthpieces daily. How about drying and irritation of mucosa? You can administer humidified oxygen. That would help to sort that out. If the client goes into respiratory depression or CO2 narcosis, what do you need to do? How can you prevent this? You need to monitor respiratory rates frequently, alternate between breathing room and oxygen at prescribed intervals, administer mixed oxygen, air and oxygen, rather than pure oxygen. Administer minimal concentrations necessary. Periodically inflate the lungs fully. In terms of oxygen toxicity, premature infants are at high risk because those that are exposed to excessive amounts of O2 for prolonged periods may develop ROP, which is retinopathy of what? Prematurity. And this may result in irreversible blindness from vasoconstriction of the retinal blood vessels. Okay, but for adults and children, their lungs, especially when they're on respirators, are most susceptible to pulmonary damage from oxygen toxicity. And you can see pulmonary damage as presenting with atelectasis, exudation of protein fluids into the alveoli, damage to and proliferation of pulmonary capillaries, and interstitial hemorrhage. Okay, early symptoms of oxygen toxicity would include a cough, nasal congestion, sore throat, reduced VC or vital capacity, and substernal discomfort. Okay, another hazard could be combustion. So be sure that electrical plugs and equipment are properly grounded. Enforce no smoking rules. And again, do not use oils on the client or on O2 equipment. A nurse checks a client who is on a volume cycled ventilator, which finding indicates that the client may need suctioning. I will just go straight to the answer. We have restlessness there. We know that restlessness, increased heart and respiratory rates, and noisy expiration suggest hypoxia. These are pure indications, core indications for suctioning. Drowsiness doesn't tell me I need to suction. Like I said, respiratory question, respiratory answer. Decision tree, always use it. To prevent unnecessary hypoxia during suctioning, the nurse must what? Apply suction for no more than 10 seconds, maintain sterile technique, lubricate 3 to 4 inches of the catheter tip, withdraw catheter in a circular motion. Okay. If you use your step 5 of decision tree, we know that A is our correct answer option. Because if you apply suction for more than 10 seconds, it may result in hypoxia. Well, although option B, C, and D are important during suctioning a tracheostomy, hypoxia actually results from actions that decrease the oxygen supply. So A is the correct answer option. So what's your procedure for suctioning? You want to wear protective eyewear, hyperoxygenate the client before, during, and after suctioning. So we're giving 100% oxygen for 3 minutes or 3 deep breaths. Explain procedure to clients. It's usually a potentially frightening procedure. Put the client in semi-Fowler's position. Lubricate the catheter with sterile water and insert without applying suction. Advance catheter as far as possible or until client coughs. Do not apply suction. Withdraw catheter 1 to 2 centimeters, then apply suction and withdraw catheter with a rotating motion for no more than 10 seconds. A wall suction set is between 80 to 120 millimeters of mercury. Again, repeat procedure after client has rested. Hyperoxygenate for 1 to 5 minutes after suctioning, especially after suctioning your endotracheal tube or tracheostomy tube. So you want to suction the tubes and then suction the mouth, and then you want to provide mouth care. So what are complications that can arise from suctioning? Like we said, hypoxia is one of them. There could be bronchospasm. There could be vagal stimulation. There could be tissue trauma. It could precipitate a cardiac dysrhythmia, and you could also cause an infection in your patient. So these are complications. Okay, so let's look at our quiz. A client is diagnosed with a spontaneous pneumothorax necessitating the insertion of a chest tube. What is the best explanation for the nurse to provide this client? A, the tube will drain fluids from your chest. B, the tube will remove excess air from your chest. C, the tube controls the amount of air that enters your chest. D, the tube will seal the hole in your chest or your lungs. Just going to go straight and know that option D is the correct answer choice. We know that the purpose of a chest tube is to create negative pressure and remove air that's accumulated in the pleural space. Okay, so let's look at some surgical drains. We know that surgical drains are tubes used to remove pus, blood, or other fluids from a wound, and they're commonly placed by surgeons or interventional radiologists. Okay, let's look at the different types. There's a Jackson-Pratt, there's a Penrose. So let's look at our nursing consideration for each of them. We know that the Jackson-Pratt is a portable wound self-suction device with reservoir. Okay, so you can see the bulb that will provide a self-suction and also has a reservoir that collects the drainage. As a nurse, you want to monitor the amount and character of the drainage. You want to notify the healthcare provider if it suddenly increases or becomes bright red. That tells us it's an active bleed. You want to notify the healthcare provider. Okay, how about the Penrose drain? Okay, it's a simple latex drain, so you can see that there. You also want to note the location. Usually it's not sutured in place, but it's layered in gauze dressing, and you want to expect drainage on the dressing. So you can see there's some drainage there already. Okay, this is a hemovac. So this is your hemovac drain. These are larger portable wound self-suction device with reservoir, usually used after mastectomy. So as a nurse, you want to monitor and record amount and character of drainage. You want to notify the healthcare provider if it suddenly increases or becomes bright red. Empty when full or every 8 hours. You want to remove the plug, so that will be your plug over there. Maintain sterility, empty the contents, and then you place on a flat surface so that you can cleanse the opening and plug with alcohol, with an alcohol sponge. And then you want to compress. You can see how it's pressed down. Compress the evacuator completely to remove air, and then replace the plug and check the system for operation. Okay, so the T-tube, which is used after gallbladder surgery, is usually placed in the common bile duct to allow passage of bile. Your nursing considerations: monitor drainage, fasten the tubing to dressings. You always want to keep below the waist, okay? And you may clamp for 1 hour before and after each meal. You may clamp for 1 hour before and after each meal. The patient may be discharged with the T-tube in place, but this can be removed after 7 to 14 days. Again, you want to teach the client about caring for the drainage system. Okay, a nurse is performing a physical assessment on a client who just had an ET tube inserted, which finding would call for immediate action by the nurse. Breath sounds can be heard bilaterally. Mist is visible in the T-piece. Pulse oximetry of 88 beats per minute. This already raises red flags for me. Okay, so pulse oximetry of 88 beats per minute. We know that it shouldn't be less than 90. even 94. So placement of the ET tube will need to be checked along with the ventilator setting. So C is our correct answer. Okay, let's look at tracheostomy care. Now, so what's the procedure to care for a tracheostomy? You want to perform this every 8 hours and as needed. Explain procedure. Hyperoxygenate or deep breathe. You want to instruct the client to do that. Suction the tracheostomy tube, first of all. And then you want to remove old dressings. Then you can open your sterile tracheostomy care kit and put on sterile glove. So we are ready. So the first you will need to do is to remove the inner cannula. So this is your inner cannula. You can see it being pulled out from the neck plate. So remove your inner cannula. You need to be sure if it's a permanent one or if it's disposable. Okay, so clean with hydrogen peroxide if it's a permanent inner cannula. And then rinse with sterile water and dry. Then you can reinsert it into the outer cannula. And then clean stomach sites with hydrogen peroxide and sterile water, and then dry. You also want to change the ties of Velcro, okay? Or Velcro tracheostomy tube holders. So these are your Velcro tracheostomy tube holders. You want to change them as needed. Old ties must remain in place until new ties are secured. Tie on the side of neck, allowing 2 fingers to be inserted under the tie. Again, you can now apply new sterile dressing. Do not cut gauze parts. Do not cut gauze parts, because you know all of those tiny, what I call the ropes or strings from the gauze pad can go into the airway. So you don't want to cut gauze pads. So document site of tracheostomy, the type and quantity of secretions, and also client's tolerance to the procedure. Okay, we're looking at the purpose of this cuff in a tracheostomy tube. The major purpose is to prevent aspiration of fluids. So it's inflated during continuous mechanical ventilation. So you want to inflate the cuff during and after eating. You also want to keep this cuff inflated. During and 1 hour after a tube feeding, you want to inflate this. When a client is unable to handle oral secretions, you want to inflate the cuff. When a client may aspirate, you want to inflate the cuff. Remember, we said the purpose of the cuff is to prevent aspiration of fluids. Okay, but be sure to check cuff pressure every 8 hours and maintain at less than 25 centimeters of water. Some complications that could arise include airway obstruction, tracheal necrosis, and also infection. The physician has ordered a thyroid scan to confirm the diagnosis of a goiter. Before the procedure, the nurse should do what? Assess the client for allergies. Well, I'm sorry, but I've become so used to this decision tree that just reading the question, because I can get I know my topic and already seen allergies and seen a thyroid scan. I already know that a thyroid scan uses a dye, so the client should be assessed for allergies to iodine. So A will be my correct answer option. Sorry about that, but when you use the decision tree, that's how it works. So let's look at urinary catheters. So what are the types of catheters? There's a whistle tip catheter, which is a straight catheter and is used for blood clot removal. There's a code, which is a curved catheter and is used for benign prostate hypertrophy to avoid prostate trauma. There's a Robinson, which is a hollow catheter with 2 openings, usually used for intermittent catheterizations. There's a filiform, which is a stiff catheter for urethral strictures. There's a Foley catheter, which is the most common double lumen with inflatable balloon towards the tip, and is used for indwelling urinary drainage. The Pisa is another indwelling urinary drainage catheter. It has a mushroom tip, otherwise it's just like a Foley. There's a Malicot with its wing-shaped tip, and it's used as a nephrostomy tube. It's usually anchored in the renal pelvis through a flank incision. And then there's a suprapubic catheter. which is placed in the bladder through an abdominal incision, and a dressing is put over the site. It's actually used in conjunction with urethral drainage. So let's look at the procedure for female catheterization. As usual, you want to explain the procedure to the client, assemble your equipment. The client should be placed in dorsal recumbent position or in Sims position. Drape the client with sterile drapes using sterile technique. Apply sterile gloves. You can see sterile. Okay, so lubricate catheter tip and place in sterile catheter tray. You want to separate the labia with thumb and forefinger and wipe from the meatus towards the rectum with sterile povidone iodine swab. And then you want to discard the swab. So remember, wipe from the meatus towards the what? Rectum. Insert catheter 2 to 3 inches into the urethra. Insert catheter an additional inch after urine begins to flow to ensure balloon portion of catheter is in the bladder. At this point, you want to inflate the balloon. You can apply gentle traction to the catheter to confirm. And then you want to tape the drainage tubing to the client's thigh. For male catheterization, if the patient is uncircumcised, you want to retract the foreskin to expose urinary meatus. Cleanse glands and meatus with sterile povidone iodine swabs in circular motion. You want to hold the penis perpendicular, okay? So you want to hold the penis perpendicular to the body and insert catheter into urethra 6 to 7 inches. Okay, for females, we said you want to insert the catheter 2 to 3 inches. And for males, you want to go 6 to 7 inches. Replace the foreskin, inflate the balloon. Again, gently apply traction to the catheter until resistance is felt. You know, this actually indicates that the catheter is at the base of the bladder. And then tape the drainage tubing to client's thigh. So what are the principles of drainage system care? 1, catheter should not be disconnected from the drainage system except to perform ordered irrigations. Urine samples should be obtained from the drainage port with a small bore needle using sterile technique. And then you clamp the tubing below port. So if you want to take samples, you're not going to take samples from this point. You're going to use, you're going to access the drainage system from the drainage port with a small bore needle using sterile technique. Drainage bags should not be elevated above level of cavity being drained to prevent reflux. Avoid kinks in tubings. Again, you want to avoid removing more than 1,000 ml at one time. If more urine in bladder, clamp after 1,000 ml. Wait 15 to 30 minutes, then continue, or you can follow your company policy. Again, coil excess tubing on the bed. So what's the procedure for catheter irrigation? Why do you want to irrigate your catheter? You want to prevent obstruction of flow in the catheter or remove buildup of sediments for catheter, for example, in long-term use catheters. Okay, for closed urethral catheter irrigation, first, you want to draw solution into your syringe using sterile technique. Then you want to clamp the catheter below the injection port. Cleanse that port with antiseptic swab. Then insert needle into injection port at 30 degrees angle. Slowly inject fluid. Withdraw needle. Remove your clamp and allow the solution to drain into the bag. So that's for your closed urethral catheter. But if it's an open system, use sterile technique also. Cleanse around catheter, and then you can disconnect the tubing. That makes it open. Gently instill 30 ml of solution. Allow fluid to drain by gravity into the sterile basin. If solution is easily instilled but does not return, have the client turn side to side. If still doesn't return, you can depress the syringe bulb to provide gentle suction. Again, disinfect the ends of the catheter tubings and reconnect when you are done. What's your nursing care for patients with urinary catheter? Use aseptic technique on insertion. Do not disturb integrity of closed drainage system. Always check for kinks. Provide perineal care with soap and water 2 to 3 times daily. Then apply antimicrobial ointment to the insertion site. Keep urine bag below the level of the urinary bladder. Secure to leg to prevent traction. Monitor input and output. Maintain urinary drainage catheter. Minimum urinary drainage catheter output should be 30 mL per hour. Please, this is very important. Minimum 30 mL in every hour. Monitor for signs and symptoms of infection, such as foul-smelling urine with pus, blood, or mucus streaks. Adhere to special precautions for type of catheter used. For example, ureterostomy or the ureterostomy tube should never be irrigated. Nephrostomy tube should never be clamped. For straight catheters, do not remove more than 1,000 ml at one time. Again, you can clamp indwelling catheters intermittently prior to removal. So let's look at intermittent self-catheterization. It's used to treat neurogenic bladder caused by spinal cord injury, multiple sclerosis, or even brain injury. As part of your preparation, you want to gather your equipment, maybe your straight or your curved tip 12 or 14 French Tiemann catheter, most common for male clients. Clean container or plastic bag. You also need a water-soluble lubricant. You need a washcloth with soap and water, and also a container for the urine. So you want to wash your hands, wash catheter with warm water and soap, rinse and dry completely. So let's look at insertion. You want to clean the perineum with soap and water. Then you want to lubricate the catheter with water-soluble lubricant. Locate your catheter insertion point. For female, you can use a combination of visualization and palpation. For males, you want to visualize the penile or the penile meatus. Insert catheter slowly until urine returns. Then advance 1/2 to 1 inch. You can also press down with abdominal muscles to promote complete emptying. Once bladder is drained, remove gently. Immediately rinse catheter with cool tap water to remove residue. Dry thoroughly and wash your hands. As part of client teaching, this should be done, intermittent catheterization should be done every 4 to 6 hours. Should be performed at consistent times daily. Use clean technique, not sterile technique. Remove 350 to 400 ml each time you carry out this procedure. Perform this procedure in a comfortable position, either sitting or standing. Use catheter for 2 to 4 weeks and then you can discard it. Store catheter in sandwich size bag or clean container. Never store catheter wet or in an antiseptic solution. The client should drink between 250 ml at 2-hour intervals or up to 2 liters at regular intervals.